not only GPs, but in some cases they were also surgeons. And as I understand, those kinds of doctors are not made anymore. If you're a surgeon, and that's what you're going to be doing all the time. And if you make that commitment, you're likely going to be working in areas that are more central, where you're going to be doing operations one after the other all the time. So that, I think, is a big change from what we're used to here. And I think if Dr. Pillay, which is really the last GP surgeon, I think pretty well that we have here, and he's if he's not retired, he's moving on, I think, at the end of the year. I talked to him a couple of weeks ago. He still has his license, but I think largely he's ready to move on. And so that is a big change, because people are used to getting surgeries here locally. And I know the operating room, it has a payroll of over $1 million a year, and it's still fully operational. And from what I understand, there is no view to seeing it close or reduce operations. There are visiting surgeons coming in, but the kinds of surgeries now are more like day surgeries, where you can come in and go out the same day. The reason being, when you have a visiting surgeon, it's not the same as a Dr. Pillay or a Dr. Burney or Dr. Boleyn who live here and can monitor patients days after the surgery, which is a requirement if you're doing surgeries like that. So I think that's probably one of the most significant changes that I see happening in Inverness. And we are getting new doctors to replace these retiring physicians. I think that's a positive. And we've recently just had 2 new ones say they're signing on. We also have telehealth, which I'm sure we'll talk about today. Access to the healthcare system, you do need a doctor or a nurse practitioner. We also have a number of nurse practitioners practicing here in Inverness now. Those developments are changing the healthcare in the area, but I do feel positive about what I'm seeing in Inverness. I will also say, though, that I know there's a feeling of some strain on the system, and I think it's largely because of closures in other areas, people coming into Inverness to the ER here and such. So, and we have as you can tell when you look along the coastline here, you see the golf course development and the changes that's brought to the community. Particularly in the summertime, things are really busy, and that adds strain to the healthcare system. So there's a couple other points here, but I don't want to take up the day. The day is for you, and I'm sure we'll be covering other things I was going to mention anyway. So, say again? I'll jump in maybe, yeah. But I'll hand the mic back to our moderator here, and hope you enjoy the afternoon's proceedings.
Thank you. Hi, everyone. So I'm Michelle Thompson. I'm the MLA for Antigonish, Minister of Health. What Alan didn't tell you, though, is I'm from Middle River. And so my grandfathers were Gordon Dandie and Frankie MacDonald, and that might tell you all you need to know about me, depending on on how, if you knew those fellas or not. So it's a privilege for us to be able to come out and talk to you all and hear your experiences and hear your solutions and hear your concerns. And we also want to be here to tell you about some of the work that we're doing. So we ran on a platform of healthcare. I was, as Alan said, I'm a registered nurse, and I've been a nurse for a long time. I was working in long-term care before I was elected. This is my first shot at politics, so I'm learning a lot in a lot of different areas as I move along. So the first thing we did was go out to healthcare workers in this province from Neils Harbor to Yarmouth, and we talked to them about their lived experience. What were they experiencing? What were their solutions? And we spent 4 days, or 2 days, 3 days, 4. I was long. It's a long drive from Neils Harbor to Yarmouth is what I'll tell you, and we were the ones that did it. So we spent that time listening and reaffirming what we thought we'd heard, and we talked to everyone. We talked to frontline staff that were delivering care. We talked to dietary staff. We talked to environmental services staff. We talked to paramedics. We wanted to hear from everybody because everyone has a different lens. And from those discussions, we built Action for Healthcare, which is the first strategic plan for healthcare in this province that we've had in over a dozen years. And that is accompanied by a website called Action for Health. And I'd encourage you to Google that. And we update that on a regular basis around metrics They're not all good yet. I'll tell you that right now. We have said we're going to be accountable, and there's no sense not telling the truth. Accountability is telling the truth, and so we know that we have a number of big hills to climb, but we're going to climb them. That's what I'd like to tell you. So now what we want to do is, now we've had Action for Health, we've gotten 15 months under our belt, and we want to come out to communities and talk to you about healthcare. We want to tell you what we're doing. We want to hear from you, answer your questions, those types of things. So that's what we're here today. This is a conversation, really. And so we're looking forward to the discussion. And so I'll turn it over to my colleagues to introduce themselves and say a few words. So thanks for having us. I'm really glad to be here. And my belly's as full as a tick because we stopped at the Dancing Goat. So if I yawn, it's not personal. I had a big lemon square, and I'm sorry I ate it before I came. I should have saved it for the way home. Anyway, all right, I'll pass it over.
Thank you, Minister. Good afternoon, everyone. As Minister McMaster said, I'm Jeannine Lagassé. I'm the Deputy Minister of Health and Wellness. This is my 6th year in the Department of Health and Wellness. I've been the Deputy Minister just the same day that Minister Thompson became Minister. I became Deputy Minister, but I was an Associate Deputy in the department for 4 years before that. I am thrilled to be here and with the Minister and Karen this afternoon. We work very closely together, and not a day goes by that Karen and I don't talk to each other, and Jeff and our colleagues in EHS, and the system is really working as a system now, I think is one of the things that I'd like to start off by saying, that for a lot of years we worked in silos across the system, and what we're trying to do now is work more together to provide you the services that you need and deserve. We're very proud of Action for Health, how it came about, how we have rolled it out, and how we're starting to achieve the actions under the plan. So we will chat with you a bit about that this afternoon. This is our 11th session of 18. And we do run it as a question and answer for a number of reasons. We want to hear your questions. We hope that by answering them, we're giving you the information that you're looking for. But we really want it to be a conversation that not too formal, but Nancy will help us out in moderating, but we really want to hear from you, and we're hoping that we can give you the information that you're looking for from us. Thank you.
Great. Hi, I'm Karen. I want to start with 3 things. I didn't actually see the article this morning, but somebody told me bits of it in the Post, I think. And it was interesting because last night at the end of our session, which was in Glace Bay, I did take a few minutes with the reporter, and she says, well, what do you hope to get out of these conversations? Like, what are you doing? What do you hope to achieve? And, I answered the question. And then I went home, and this morning I got a picture. And it was one of the outcomes of a session. I'll explain what the picture was. So we had a session in Cherrybrook. I don't know if people know where Cherrybrook is, but it's part of the Prestons, and we had our session in the Black Cultural Center. And it was a difficult conversation, very intense. And at the end of the conversation, a young woman came up to me. She was from Nigeria. She was an RN, and she had moved her family, her husband and her son, to Nova Scotia. And she finally landed a job just in May with Nova Scotia Health. And she said, I have friends that want to work in the healthcare system. Some are home and some are here. And I said, great, give me your name. You come in next week. Let's get into it. She did. We've already had a session once this week already, and that was the picture. There were 8 Nigerian friends of Eunice who want in. And of course, we want all of Eunice's friends and as many as she can possibly open the door for. So if an outcome was to find a new pool of people that are interested in either working and or coming to Nova Scotia, I think that's a pretty good outcome. So I'm excited for what might come out of today, to be honest with you. And so that's just one story. I digress, but I was really happy about that. So what The second thing I like to do is just a show of hands, the healthcare workers in the room here today. If you could just say who you are. So they're mostly in the back and a couple in the front, maybe a couple of people that would like to rejoin the system. So I want to say thank you. Thank you for your efforts. Thank you for what you do. And I like to remind folks as well that, 3 years ago at the very beginning of the pandemic, there was a lot of pot banging and hand clapping and Tim Hortons gift cards and a whole bunch of good things for our healthcare heroes. And somewhere along the way, that just faded away. It just faded away. So I like to remind us to make sure that we take good care of each other and to make sure that we treat our healthcare workers with kindness and with respect. And with that, third thing, I like to introduce some of our local leaders. So I like Brett and Dr. Brian, and if you want to bring Michelle and Glenn, it's up to you, Brett. So we did this last night, and that worked well too because Brett's phone rang off the hook this morning. So I'd just want folks to know who you're dealing with here, and I just ask them to quickly introduce themselves and what you're into. So thanks, Brett.
All right, thanks. Thank you, Karen. So Brett McDougall, registered nurse. I've been working in the healthcare system in former CBDHA, Cape Breton since the late 90s. Currently the Vice President of Operations for Eastern Zone. I was previously the Executive Director of Operations for the Eastern Zone. I've been down to Inverness many a time. And to Minister McMaster's comments about working with peri-op services here locally. So have the background on all of that. So yeah, I think it's great to have our leadership for the province here in relation to healthcare. It's a great opportunity for the community to engage and have discussion. Happy to meet everybody. Certainly, I'll be around after the event, and if there's anything that you want to bring up in relation to a local context, happy to have those conversations. And I'll hand it over to Dr. Brian.
Thanks, Brett. My name is Don Bryan. I'm an orthopedic surgeon. I'm based in Sydney. I'm originally from Dartmouth. I've moved here 25 years ago. So I have a really close connection here. As an orthopedic surgeon in Sydney, this side of the island is always very busy, particularly in the summer. So I get a really good relationship with a number of the physicians here. Minister McMaster mentioned the legends here, so I'm dating myself. Actually, Brett and I started the same years. So, but I had the luxury to work with a number of those names you mentioned. A number of them are stepping away, and the nice thing is there's new ones stepping in, and as legendary as those physicians were, I'm really excited to see the new ones. They are a little more specialized. The training's a little bit different. They will practice different. They're going to work equally as hard, and they're equally as dedicated, but they are working differently. And if I'm not mistaken, I think one of the new physicians, we signed them yesterday, if I'm not mistaken, Dr. Bindersley. So, so that's, just real excited here and, working with a number of the physicians here. So kind of that's my role. I'm the medical director, so basically representing the physicians part of things. What are trying to create and develop the medical plans and medical services that we can deliver. Obviously, as physicians, we need to work very closely with all the other administrators and managers here. We can't do it on our own. And it's really nice now that I think just see the group of people around the room here. This is how dedicated we are. And it's every place in the province, and I'm really proud of that, to see the healthcare workers. We take this very serious. I know we're going to have some discussions today, some hard discussions, some emotional discussions. That's why we're here. We want to hear it. We will hear it. But I've been consuming medical resources for the last 25 years, and a lot of them as a surgeon. Minister probably knows that. We spend a lot of money, but it's you people that we're serving. And being here for 25 years, I've seen ups and downs, but I can say over the last year and a half, I've never seen more of an interest and an impetus and momentum for healthcare. I'm dating myself again. My first job was in Alberta, Premier Ralph Klein. I moved out there, and I think I was there for 2 months, and he said, "Guess what, Dr. Brian? I'm going to take 10% off your earnings." So that's when. So we went through that decline or destruction of healthcare to a point where we are now. It's complicated, it's complex, it's difficult. We don't have the answers. We are working hard, and this whole group of people around the room are working really hard to try and help fix that. So that's we're glad to be here, and that's why we're here. So thanks.
Good afternoon, everyone. My name is Glenn Cox. I'm the Executive Director for Community and Rural Health, as well as responsibility for pharmacy, lab, diagnostic imaging, and rehab. I'm a registered pharmacist, born in Cape Breton, and have lived here all my life. Actually have spent some time in Inverness coaching hockey against, I believe it's still Cape Breton West, and have been indoctrinated into the harness racing profession because my father-in-law is involved with horses, and my wife is very passionate about it. So I've spent a number of Sundays here on the weekends on the fence watching races. So spent a lot of good times in Inverness. Have used the emergency services here again on nothing serious, but know how important those services are. Took some hockey players to the ED department here about 10 years ago, but still it was there, and we know those services are important, and again, just very happy to be here. And just the fact, if you go back far enough, I think you can find any ties to community, because my father-in-law's uncle, I believe, was Dr. Harold Ratchford, and he worked a number of years ago in Inverness, so it was, he told me that before coming here, so it was very good and very timely. Anyway, very glad to be here this afternoon. Thank you.
Good afternoon, everyone. So I don't have any Inverness stories. Not yet. I like to tell everyone, that's right. I'm a new Cape Bretoner. My name is Michelle Podesta, and my family and I moved to Sydney 2 years ago from just outside of Vancouver. So really excited to be here. I've told everyone now it's been 2 years, so I think we get to call ourselves Cape Bretoners. And I was telling someone yesterday, my 16-year-old, I think when we first told her 2 years ago we were moving to Cape Breton from Vancouver, she thought, oh my gosh, where are you moving us to? But she told us last week that moving here was the best thing we ever did for her. So that's good news. My day-to-day responsibilities, I'm the Executive Director of Acute Health Services and Primary Health Care. So what that means is really looking at our big regional sites, so our 3 community hospitals in Cape Breton Regional Municipality, as well as our 2 larger regional hospitals, so Cape Breton Regional Hospital and St. Martha's Hospital, and looking at our surgical program, our emergency program, and then tying that into primary health care. And I think on a day-to-day basis, really looking at how do we increase access. And one of the things I'm passionate about, while I have responsibility for a lot of acute care services, how do we keep people out of the hospital? We need our hospitals to act like hospitals when people are really sick, and we need to get you the care you need. But then how do we tie that into the community? I'll introduce Andrew Heighton, who's at the back, who's our Director of Integrated Rural Health. Andrew and I, along with Sarah O'Brien, who isn't here tonight, the Director of Primary Health Care, have a proposal in, actually, looking at a national research project based here in Inverness, looking at how do we create care pathways from emergency departments to primary health care. And so you have a great emergency department here, you have a great primary health care clinic, and I would say to you, we need to really look at funneling those 2 streams of care a little bit more efficiently. So fingers crossed that proposal was submitted 2 days ago, and fingers crossed that goes through. But just wanted to highlight some of the innovative discussions and work that's happening right here in Inverness. So really excited to be here tonight, and thank you for having us.
Great, thanks guys. So now you know the team, and there's several others behind, and so I really appreciate everybody coming, and roll it over to you, Nancy.
Okay, so now we're going to start. Is this on? Okay. Oh yeah, I can hear it. I can hear myself now. Our formal question and answer period. So essentially what we'll do is take turns asking questions. I have some that were submitted ahead of time. So if you submitted a question and you want to ask it yourself right now, you can just put your hand up and we'll go around. Every time we do this, and I kind of stand up because I can see better, so I'm going to move over here so I can see who's got their hand up. What we've had to do, depending on how many people and how much interest, you kind of do a little of the pointing thing, which I know is really, I always think of the don't point and how rude it is, but I have to do it. It's the only way we can make sure we are getting to the people, that everyone that wants to ask. If we run out of time, so if it gets really busy and we run out of time, I would ask you to write your question on your card with your email address, and someone will get back to you with an answer. We try to get to as many people as we can, one question at a time, and then if we have time to go back to people. So if you have more than one question, we'll take one question and then go to someone else. If there's another question, then go back, if that makes sense. So does that work for everybody? Please, thank you. Good. Yeah, so I kind of feel like there's something else I'm supposed to say and I can't think of it right now. So I'll go with their questions and it might come to me and I will share it then. So the first question, I'm going to start with a submitted question because I find that kicks things off and gives us a little flavor for what we're looking at. So the first question is a submitted question around midwifery. And the question is, how do we improve midwifery services throughout Nova Scotia?
So I'll start with around midwifery. We do have some midwifery throughout the province. Of course, there's some at the IWK, and there is some throughout the province. And I know St. Martha's Regional Hospital. Brett, you might want to add in here a little bit if I don't hit the mark. But so we do have midwives throughout the province. It is what's important about it is that we do it thoughtfully, I guess, is what I would say. We are trying to build a primary care system that involves a number of different folks, so nurse practitioners, physicians, family practice nurses, all of those folks, and midwives are a portion of that. When I lived in Scotland, I really never saw a physician. It was all midwives. And when you went into nursing school, you took 1 year together, and then you either became a nurse, a registered nurse for whatever, a midwife, or a mental health nurse. Actually, is how their program was. So midwifery was very different than it is here. I think what I would say is it's evolving, and we're future facing around midwifery. Do you have anything you want to add, Brett, around the program? It's there. We're not. I don't know if there's any expansion plans or not from the current model that we have.
Yeah, so you are correct. There's a midwife program in Antigonish, St. Martha's. There's also a program in South Shore. One of the sort of features of midwife program is you need a cohort of midwives to ensure that there's coverage in relation to the on-call. So the program is built in relation to cohorts of 4 midwives collectively. So IWK has 8, I believe. Antigonish has 4, and then the Yarmouth location has 4. So one of the complexity also with the midwife program is any training is outside of Nova Scotia, so it is challenging to recruit midwives, but certainly something that I think the province is reviewing. I don't know about our plans to expand today, but it's certainly complementary to the OBGYN services within those locations where they exist, and certainly in the IWK. So it is a benefit to women and women's health, but it would have to be further explored, I believe, at this point. But very valuable service.
Perfect, yeah. Mike right there.
It says there's possibly plans down the road for midwifery for our region. So somebody in Inverness that's going to have a baby has to drive to Antigonish or to Sydney. So I think I'd like to see more of a commitment that you're going to do something about moving the art of midwifery to the more rural communities.
So I can't give you that commitment today because of the things that Brett just spoke about. Number one, the training does happen in Ontario, and so we don't have our own supply, for lack of a better word, and to the point that we would have to look, we have to be very careful with our resources is what I would say. So I don't know what the birth rate would be here, the number of babies that would be born in this hospital, because one of the things that's really important for all of us as clinicians is that we maintain our competency. So in order to maintain competency, there would be a number of births per year that people would have to perform, and also who would be the midwives backup in the event that there were complications. So it's not as simple as just adding that one resource or two resource. It does require a program. And so I think that's more around the whole obstetrical. Some folks want midwives, some people would prefer. We have primary care OBGYNs now, so those are primary care physicians who actually deliver babies, and I know there's a number in Antigonish as an example. It isn't just obstetricians that deliver babies, so it is a complex program. I think there used to be a number of deliveries here years ago. I don't know. It would be something we would have to look into a little bit more, is what I would say. Yeah.
Thank you. And I remembered what I was going to say is if you have a question you don't want to read, you can write it on your card and just give it to me and I'll read it for you. So if you have something that you don't want to read, that's what I was going to say. So is there any questions from you guys? Okay. And we have people with mics. That was the other thing. So we have people with mics that will come around and bring you the mics so you don't have to get up. So, okay. Well, actually we have, okay. Yeah, you go, you can be 1 and 2. That's when my pointing starts. Thank you. You can be 1. And then
Fine.
2. Thank you.
Oh, get me up here for a second to stretch. I have a concern that affects like here, plus I'm sure it affects like the whole province. And that is our RCMP members when they take, say, a patient to the hospital and they are sitting there for hours with that patient. And I mean, we might have two officers on duty. And if you have one at at an outpatient sitting there for hours, and then they're seen, the patient is seen, and it's like, okay, they have to go to Sydney. Then the RCMP member is transporting them to Sydney, and they have to start all over again, being assessed when they get to Sydney. So it's leaving us vulnerable here without protection. Or proper protection at some point. So I'm wondering, is there something in the system that can be done for those situations that would help? Like, I mean, it's 2 problems, right? Yeah. So is there something that could be looked at for that? Thank you.
It's a great point. Actually, to be honest, in our 10th session, this is the first time the point's been raised. So it's an excellent point because it's really 2 problems. And so I don't know the answer. However, I've just made a note, and I think we need to do a little work, and particularly on the policing side. That's the point that I would need to, follow up. Oh no, I can see that because your RCMP resources are stretched thin to begin with. Got it. And I have a sister as a police officer who spent many hours sitting in the ER and feeling like she's not contributing to her community as much as she should. So I got it. Don't know the answer. We'll find out. Yeah. No, it's a really great point. Yep.
Because I'm on the RCMP advisory board, I'm the chair. And when I talk to members, this is like a huge issue, right? So I always said if I have the opportunity, I keep bringing it up and hoping that we can find a solution. Yeah. You're welcome.
Yeah, thank you very much. So we have sorry, now I'm pointing at the mic people. So we have a question here. Sorry.
I'll be back.
I don't think I probably need a microphone, actually.
I think for the recording we do. Yeah, sorry.
My name is Ruth Skinner, and I'm local, and I'm an old, retired emergency room nurse. I know recently we've lost a few nurses from our area for various reasons, potentially financial, potentially too stressful here. My question, and I'm not sure who to direct it to, but I would like to know what we're doing about recruitment and retention. Not just nursing, I'm talking about diagnostic imaging, I'm talking about lab workers and workers in our healthcare system in general. I have a bit of an idea about the physicians, but it's the other healthcare workers that I'm interested in knowing just a brief overview of what the plan is.
Sure. Do you want to start, Minister? So we could take 2 hours talking about that. So I actually love the question, and it's a very important question because at the end of the day, it's all about the people. We can build hospitals, we can buy equipment, we can do all these great things, but if we don't have the people, we don't have much. So why don't you begin? You're the minister.
Okay. Yeah. They fill in the gaps, right? They color in the lines. I will tell you that there is a lot, and so first of all, this is what we've known for at least 15 years that we were going to be in this position. We've known that. I don't know why we didn't address it. I don't say me because I was working at the front lines, but I mean the royal we. The royal we was so we're behind now. So the first thing is we've increased the number of seats across as many designations as we can to grow our own. And one thing I will tell you, every community we go to, we tell folks, if you know someone that has an interest in healthcare, the youth in your community have an opportunity to live and work and contribute to their community forever, as long as they're here in healthcare. So encourage the young folks in this community to consider it, is what I would say, number one. So we're increasing the number of seats, nursing, physician seats. There's an MOU with an organization called Michener Institute to look at some of the things that you just said, lab techs, diagnostic imaging. And how are we going to increase the workforce? So that's one. The second thing is also giving people an opportunity to ladder in their careers. So if you are, as an example in nursing, if you're a CCA, if you want to move through the potential of becoming an LPN or an RN, nurse practitioner, all of those things, we want to make your ladder easy. Same with primary care paramedics. If they want to become advanced care paramedics or critical care paramedics, we want to make sure that everybody is able to access the education that they want. And then the third thing is around immigration. So you can give me the right number, but we could accept 1,500 nurses today in the healthcare system.
It's actually 1,667 vacancies
There you go.
today.
So we absolutely need in-migration. So if there's people that are working away, we want them to come home. And we are working with the colleges. We are looking at internationally educated graduates across all designations to come and work here with us, and working with the college to make the licensure easier. There have been a lot of barriers, and physicians and nurses particularly have told us about those. We heard it on the tour, and it has been a drag. And so we are working with the colleges. So things like taking away the mid-career, like when you come in, if you're mid-career, you don't need to do the exam. Like you can just imagine trying to do an exam 15 years after you graduated. Taking away some of these barriers, looking at competency-based assessments. So like if you're good at your job and you are a doctor or a nurse or whatever you are somewhere else, why can't you be it here? And if we can't register you to the fullness, then what is the best and highest use in our system that we can offer you so that you can still contribute to healthcare? So that's at a very high level. I'm sure you folks have things to add, but very, very focused. We need that. And one, new people are retention, right? So when you're not working short all the time, having a fullness, that stress that you experience, that is part of retention. And we are working with the unions to understand each designation has particular struggles, right? So I know Kevin McMullen is here somewhere. I don't know where he's at, but he's there with the paramedics union, like working really closely with him and his colleagues to understand how do we improve work-life balance for our healthcare workers now, because a lot of them don't have it, and they don't have it because we have so many vacancies. So I will tell you there's some work that's started and completed, but there is a lot of things in the pipe trying to get and untangle the knot to support our healthcare workers, because we need a ton of them. So I don't know if that helps. These guys will.
Yeah, and just picking up on a few of the things that the minister said, kind of non-physician recruitment in particular, I think was your question, that we're also looking at just even streamlining our recruitment procedures, right? Because and how we get people in, how they apply, single entry kind of places, and then being able to do some back office work to streamline them to the types, if they want to work in long-term care or at the NSHA or the IWK, because really we've heard that process is cumbersome, and just then when they've applied, just to the time it takes to get through the recruitment process. So I know Karen and her colleagues in the health authorities have been working really hard to even do that, because it all helps, right? So that if someone applies and then they don't hear forever, or it takes them a really long time, we heard a lot about that when we did Speak Up for Healthcare. So in this last 15 months, we've done a lot of work on that. And then the government created in September 2021 as well, the Office of Healthcare Professional Recruitment. And so what the office does is really look across the whole system and our government partners. So in immigration, as the minister said, if there are ways that they can help to streamline they're doing it. So it's kind of multi-layered. So there's the actual people going out to find people, but behind that, there's a bunch of policy and procedure work that we're doing to make it easier for people once they do come forward.
Yes, all of the above. I just want to maybe comment a little bit on retention, because we talk about recruitment. So, you know, retention is equally, if not more important than the recruitment. And, you know, I need to say that because we get a lot of healthcare workers in the room. But it's true. Once you're in, it's a lot, if we, you know, if people feel valued and they're treated properly and they like going to work and they're kind of having fun with it and can grow and learn, it's great. So we hear a lot about value and respect, a little bit about, I shouldn't say a little, lots about compensation and as well retention bonuses. And it's a really tough time of year, not just the fact that it's December, but the fact that our healthcare workers are stretched so thin across Canada, and it's a global issue right now. It is a global issue. So that, I don't know, you may have even heard on the radio earlier this week where, you know, respiratory technologists, RTs, were poached out of Newfoundland for a retention bonus. I think they went to PEI. It is not a good thing for Atlantic Canada to be, that's not good. We shouldn't be doing that. That's not helpful. That's not good for Newfoundland. It's just not good. So the dollar thing, okay, I'll pay you $750, I'll pay you $850, I'll pay you $1,000. Like that doesn't solve the problem. It really doesn't. So how I have tried to answer the point on the retention bonuses, we have lots of incentives in different parts of our system, particularly where there are hard to recruit areas. Sometimes it could be tuition, sometimes it's bursaries. Like there's lots of different ways to skin a cat, okay? So there's not just one thing. So people who are interested in, you know, if there's a problem, then I would strongly suggest people come forward, see if we can't fix the problem. On retention bonuses generally, you know, we had a question last night from a young nurse who was from Cox Heath, and her question was around retention bonuses. And my answer to the question is, you know, we're heading into collective bargaining with our nursing unions. And in Nova Scotia, we have the largest population in Atlantic Canada. We have some of the largest hospitals. We have the largest teaching hospital. Our nurses are very experienced, and I would fully expect them to be fairly compensated in relative terms. So, you know, I don't have, even though the minister's sitting here, like the money just isn't raining out of the sky. Not yet anyways. Not yet. But I want to make sure that our people are treated fairly and are well compensated. We have to. It's a very competitive market. So we definitely know that. But equally, like we've got to find the ways for people to be able to go home and have dinner with their family and maybe stay there instead of go home, have dinner and go back to work, or go home and walk the dog and go back to work. So it's, you know, it's many, many things. But definitely high on our, like we get it. It's on the radar screen for sure. And I'm all ears if people have suggestions or ideas on either the recruitment or the retention. So just final story. And then Jeannine, maybe you could say what we've done on CARMS. I'm remembering an email, and maybe the person's here. You don't have to reveal yourself, but it was an email from somebody in Cheticamp, and it was about their daughter who was studying to be a physician, fully bilingual, went away to the University of Sherbrooke to complete, and but wanted to come back, wanted to be back in Cheticamp, and just couldn't get a residency. And so ultimately, you know, took a position somewhere else and is still fighting to get home. So we really have taken those kinds of emails to heart. We get a lot of them from people in all over the island and all over Nova Scotia. So we have actually found a bit of a solution for that, which, yeah.
Sure. So there are a number of Canadians, Nova Scotians, who study at other medical schools, in particular in Canada, but there's also a lot who study internationally. And it's very difficult for them at present to get back into the Canadian system. So back in the summer, I guess it was, the health leadership team met with the people who run, there's a matching service for people who finish medical school then to enter into a residency program. And what we found out through our discussions with them is that we could target some of our streams for residents to come in. So we have created for the 2023 intake year a new stream for internationally trained Nova Scotians. And so specifically, you have to be, have a connection to Nova Scotia, have trained outside of Canada, and we are specifically targeting those people so that they will hopefully be able to come back into the province and practice here.
Oh, we're trying everything.
I think that leads to a submitted question that I'm going to ask you that kind of feeds along that ideas or opportunities. So the question is, has the government entertained an incentive program to entice young people to enter into an RN or LPN program, such as assisting with expenses to attend university and have a return of service with, say, 1 year for every year of assistance rendered? The high cost of tuition and housing while obtaining a degree is a deterrent to anyone considering this career choice, given that it takes years to pay off student loans.
I'll start. We have done a bit of work, and we continue to do that. So I will give you an example around continuing care assistance. So continuing care assistants, I don't know if there's any folks in the room who are continuing care assistants. They are particularly the backbone of our long-term care sector, continuing care sector, and certainly are also very important in our acute care sector, where they support really the most intimate and personal care in our system. So we have, because of the gap in that workforce in particular, the impact that had was that there was a number of beds across the province, long-term care beds, that were closed. And we weren't able to those folks that were in hospital were not able to access those beds. And so we recognized that we really needed to help that sector. And so tuition for continuing care assistants in the province has been waived. And we've also looked at different models, delivery models. So you can go to NSCC and you can enroll, and some folks really benefit from that type of learning. But if if you have a mortgage or you pay rent or you have children or whatever, it's not always easy to step away from your career and just, do all that stuff. So long-term care facilities now are able to look at your life experience, and they look at the prior learning that you have, and they do an assessment with you, and then while you work as a continuing care assistant candidate, you actually can work in a job and take modules online with support to achieve that certification, which is really helpful, especially in smaller communities where I know you have a long-term care facility here. We often have our own cultures in those long-term care facilities, and we're able to train our own staff like we did probably 20 years ago, as one example. We are looking at different opportunities across those hard to recruit professions. So we know that we have a role as a provincial government to support them, and also there is some tuition relief programs through the federal government as well. So in terms of encouraging folks, there is ongoing support, and then post-graduation, what can we do around sign-on bonuses and things like that, especially if you're coming back to rural communities. So there is some early work happening, but maybe you folks is there anything else you want to add?
Three thoughts. About this time last year, Minister, you may recall the government made a decision to offer full-time employment to every nursing grad in this province for the next 5 years. And I remember very well the day the Premier said, "Karen, can we really do that?" And I said, "Yes," because I've looked at the numbers, the ins and the outs, and yes, we can. And so that's one positive. And so now but it's important because we're graduating, a number of RNs, but that doesn't mean those RNs want or need to stay in Nova Scotia. So they have choices. And in particular, right now, we're really competing with a group called travel nursing. And it's really scary because a young person, what a great way to see things for a couple of years. And if I was that age, I'd be very tempted to do it too. So okay, maybe that happens for 2 or 3 or 5 years. So the key is not to lose touch with that person who eventually will want to come home, highly likely. So, you know, it's a competitive market. So we have those job offers, but we also have, there are a number of communities in, and I don't know what exists here by way of a foundation. I'm sorry, I just don't know. Do you have an Inverness? Is there a hospital foundation? Oh yes, how could I forget that? How could I forget that one, Minister? How could I forget that? Jeannine can talk about that. Anyway, but there are a number of foundations around the province who have really have started to put their toe into helping. Especially hard to recruit and hard to retain positions. So, for example, and again, it came out of one of our community conversations, the South Shore Regional Hospital Foundation they've hired somebody specifically to help with recruitment and retention, and that is a paid position. I don't know that it's full-time, but it is a paid position, and it's not just nurses and physicians. It's especially the hard to recruit. And so, you know, there could be opportunities. The other thing I was going to mention is that the province, just for the community, you may know this and you may be able to find a spot for this. The provincial government in the last month or so announced a $2 million fund for communities to access to help to recruit. And so that's available to help with marketing efforts, and there's a whole list of things that would be eligible. So I never like to see money left on the table, especially in the finance minister's area. So I'll just throw that out there too, because we should be using everything that we have to throw at the problem.
Yeah, I just have one last comment, and that's no matter whether it's a physician or a nurse or a paramedic or a lab or DI tech, that really what gets people to stay in the community is the community. And so really, you are all recruiters and retainers within your community. So when these people come to work in your community, it's very, very important, right? For whether they are people who used to live here and have come back, whether they are people, international people who have come to join us, that it's really important that they feel a part of the community. So we just ask that you do, really welcome them into your community and make them feel part of it.
Thank you. Oh, I have a question here. Just one second. Got to get you a mic just so you can be recorded.
Sort of comment on the retention of in primary care specifically. So I'm a retired nurse practitioner. I'm from here. I had my education and my career in Ottawa, and I retired last year. But in my demographic, there's people are just leaving primary care because of the volume of the work. And I don't think it had to do with the work itself. People, the physicians and nurse practitioners and registered nurses that I worked with in our community health center, and I think by and large really liked the work very, very much. But whether it be the electronic medical record, it's a different way of working. They're not new. I've gone through 5 or 6 of them, but they sure do generate 24/7 work. And the expectation from communities and governments to see more patients, add to it, that must be addressed. And people working in silos has to be addressed, because communities and individuals and families need access to care. And, not everybody's going to have a physician. And we have to know that. And nurse practitioners, I'm waving the flag for them, do much more than treat urinary tract infections and ear infections. And I'd like to hear more about that here in Nova Scotia, about what a nurse practitioner is doing, what a practice of a nurse practitioner looks like, and ways that teams can work together, hubs, teams, whatever you want to call it. But if we continue as clinicians to work in silos, we'll just have more of the same. And it has to be broader, it has to open out more. And in primary care, depth of the, talking about scope of practice, there's no borders to that scope. You know, a family doctor's physician role today, a nurse practitioner in primary care, the expectation is mammoth for the job that they do.
So this is, you know, thank you very much for the comment. So basically, several things get wrapped up in this. Scope of practice, practicing in a team environment, the health home. So if you don't mind, we'll just take a few minutes and talk about that. And I think it's very important for this community as well. I mean, every community across, but this is one of the reasons that we are trying to, you know, have this dialogue across Nova Scotia, because you would never say never. However, I think the days of every single person having a family doctor are probably in the rear view. So what do we do about that? And we've been spending a lot of time worrying about that and thinking about that and how do we solve that. So I would like to actually talk about that, talk about our primary care clinics and our collaborative care clinics and the so-called health home and so forth. So do you want to start, or where do you? Okay, I'm on a roll. So let's start with nurse practitioners. We have 178 now in Nova Scotia. We just increased the seats at Dalhousie from 25 to 40. Almost since I've started, so 15 months, I can remember having a very early conversation in our Speak Up for Healthcare tour, and nurse practitioners telling me that, you know, we could do more, we can do more, we can do more, we can do more. Stuck in my head. And then hearing many sides of the many perspectives, I guess. You might have physicians that feel that there's a particular role for a nurse practitioner. You'd have another physician that sees a different role for a nurse practitioner. So as many people as you talk to, you could get different perspectives. However, at the end of the day, we have to look at it this way. So there are many healthcare providers in the so-called chain. So, you know, the CCA, the LPN, the RN, the PT, OT, you know, et cetera, all the way. The paramedic, I don't want to miss anybody, but you get the drift. So what has happened historically is that everybody's kind of been pigeonholed, and maybe this much of the work gets done because they're not all working to top of scope. So this much work gets done. And if each person in the chain was enabled, empowered, asked, encouraged, whatever word you want to put in there, to work to the top of the scope, all of a sudden, this is what it looks like. Okay? So let me give you a practical example, and then you'll see where we're heading. We have a partnership with Dalhousie on the Dalhousie Family Medical Clinic. And we have, NSH has clinics, similar types of clinics around the province. But we started with the Dalhousie clinic because it was the closest, and we have the most amount of people that could help with the project. So we wanted to go into the clinic to see, to test this hypothesis. What if we had everybody working to the top of their scope? And we put a team together that was also comprised of 2 industrial engineers and a number of other people. And they went in for 4 days, Thursday, Friday, Saturday, Sunday. By Friday night, my lead phoned me and said, Karen, without blinking too much, we can take 2,500 people off the Need a Family Practice list. By Sunday, the lead called and she said, we've all agreed we can take 3,500 people off the list with some adjustments to how they're running the clinic, and we've found a way to better help residents going through the clinic so that they're more prepared to take on a practice and a bigger practice when they start. And the model we've come up with is scalable. Now here's why it was important, because we had asked, I have to be careful, I don't want to tell too many secrets out of school, but we'd asked Dalhousie to help us with this clinic, take more patients. And they were very willing to do so, no problem there, for 13 more, I think, was it FTEs or just physicians? Anyway, it was 13 more people and $26 million. And we said, yeah, let's see if we can go another approach, because I really didn't want to hit up Minister McMaster quite then. So we put the team in, and they came up, it was far less than $26 million, far fewer than 13 people. And the whole trick of it was the right person doing the right thing in the clinic, including the onboarding. So what we learned through our evaluation is that it takes a physician, on average, between 60 and 90 minutes. It takes between 60 and 90 minutes for a new patient to be onboarded in a medical practice. So if you have a physician doing that, that's 60 or 90 minutes that the physician isn't seeing 5 other people. And who is the right person to be doing that onboarding? So we created a rapid onboarding team. They're doing the onboarding, and they're also working with to smooth out the schedules and do all kinds of the back office stuff that puts the physician and the nurse practitioner, the PT, the OT, the other folks in that clinic doing what they should be doing. So the team is now, we've perfected the team. They're available to any physician's practice in this province who wants to take advantage of having them take a look at the schedule and how they can be helped, as well as any specialist group in the province too. So we've created our own kind of in-house experts that can really go into a practice and help them. So we're looking for the coalition of the willing, and then after, you know, if it works very well, you know, we will double, triple the team, send them out, work it out. So that's a little bit on nurse practitioner and a little bit on practice, and maybe you could just talk a little bit, Jeannine, about collaborative practice and how that would work.
Okay, so really what we've been trying to do, and I think that Dr. Bryan spoke about this a bit in his introduction, that we know that physicians are practicing differently now, that there's not, that a lot of the physicians that are coming out now want to do not just office-based practice, right? So they do some office-based practice, but they also want to be doing a number of different things. So what we've been doing is looking at, well, how do we do that? What do we do around that person? Who else should there be on a team? Because we also know that most practitioners now want to work in a team-based environment. So we've been looking at things, because what we really want for communities is to have access to care that is ready, responsive to when you need it, and reliable. That's the big thing, right? The reliability of it for when you need it. So a couple of the things that we've done is we've been working, as Karen said, in hopefully streamlining some of the collaborative practices that we already have, and looking what we really need in community for people to be able to attach to more of a health home, right? So you have a place where you can go and get the services that you need, but it might not always be from the same individual or from the same type of practitioner. So it's really thinking differently, right, about when you need to go to access primary care, not just going to the doctor's office, right, that you're going to where your health home is, and that there will be someone there who can provide you the service that you need. We've also been looking a lot at virtual care, that we know through the pandemic that virtual care it took off in a manner that it hadn't been before. So although there are a lot of people on the Need a Family Practice Registry, that we know there are a lot of people without a primary care provider, everyone who is on the list now does have access to virtual care Nova Scotia. So we've been talking a lot about what that means for people, not just while they're on the list, but broader, right? What is the future of access to virtual care in your health home practice or otherwise? So that's something else that we've been looking at. I'm just looking down my notes here too. Oh, the Pharmacy Plus model. We've entered into, NSH has entered into, partnerships where we have nurse practitioners in some pharmacies now, because we know, again, scope of practice, there are a number of things pharmacists can do, there are things the nurse practitioner can do. So again, just really looking at a number of different models, because part of the work and part of what Action for Health is attempting to do is like, we know that we're in a place now where tinkering around the edges isn't going to get us where we need to get to, that we really need to transform how we're thinking about providing and accessing services. So it's we're trying a bunch of different ideas now, and working with community, making sure that it's the services that you need within your community. But we know that it's not going to be the same that it's always been.
I'd like the minister to maybe talk about the mobile clinic.
Perfect.
Because you came to the first one, which we stood up right after the hurricane.
Yep. So within 24 hours of Fiona, down in Sydney, Nova Scotia Health was able to stand up a mobile clinic. It's by the John Deere dealership. I don't know if that helps. Is it by Alexander Street? Maybe, I'm not sure. Do you know where I mean? In Member 2, I think. Anyway, so it was there. It was run by nurse practitioners. There were paramedics there. There were physicians there. There were social workers there, and they did everything. There were babies there, brand new, and there were seniors there. And you went, and you just, it was amazing. When I first went there, it was freezing cold, the wind was blowing. I thought, oh my God, this is a nightmare. Like, how is this gonna roll? And I got there, and it was the most energized work site I have ever been on in my life. One of the nurse practitioners canceled her vacation to go work there. She was done. She's like, oh no, this is way more fun. And they were there, and they were working, and they were meeting people where they were getting prescriptions filled. They were doing all kinds of things, and it was wonderful. And that clinic is now going around the province in certain areas to offload the emergency rooms. We have it on Cobequid. It's been in Antigonish for the students. And the access is there. So there's attachment. We talk about attachment, which is I have a primary care provider, and we have access, and they're not always the same thing. So we are looking at what is the opportunity. And, you know, we also heard there's a lot of nurse practitioners who couldn't get work in the province. So Karen goes on LinkedIn and says, if you're a nurse practitioner, contact me. Oh, they did. We found a ton of nurse practitioners.
50. I got 50, and it was really exciting. And they got put to work very quickly in different kinds of roles. Okay, this is, I think, the other important thing. So many, look, you know, Jeannine mentioned, or the minister mentioned about students and young people. I mean, when you look behind here, like, there's a lot of young people in the back. To me, that you look young. But
you got your masks on.
I'm very inspired, is what I'm trying to say. And when you think about the jobs that exist in the health sector, there's many jobs, including a lot of technology, like all the high-end, interesting things that students are into. And, you know, there is no reason, none, that somebody with a BSc from St. FX or any of our other universities can't find a role in our health system. They may, and it doesn't need to be BSc, but, you know, that's kind of a science inclination. It could be kinesiology. It could be any university degree. It doesn't even need to be university. But here's my point. I think we sell ourselves short, and NSH hasn't dug hard enough to try to find new ways of defining jobs so that our young graduates can land. Like, this is very important to me as a Nova Scotian. I want to see our grads stay here, and I know that our healthcare system is a good place for them to at least start. So anyway, I'm really enthused by it, and I think that we have a lot that we can offer. Definitely. Sorry, we digressed. I didn't even know where we got off there. Sorry.
Get excited.
Sorry, I got excited. I'm sorry. I totally digressed. What question are we on?
I don't know. No, that's awesome. It's funny because as we do this too, I get caught up and I do the listening and forgetting the questions.
I mean, robotics, okay? I want to, here's something I want to ask Minister McMaster, because I asked him just briefly before we started. Sorry, Nancy.
No, that's okay.
You know, Jeannine just mentioned virtual care. Okay, great. It is great. But in some communities, we have an older demographic that A, might not have a computer, B might not be connected to the internet, or C, may find virtual care like complicated. So I asked the minister, like, how are we set up here for internet, for starters? And maybe you could just comment, because it's not just the Inverness community, but it's kind of broader too. And I think it's an important question because telehealth and virtual care and related things will be part of the future. So if you were not connected, hard to be part of the future.
Definitely. And when we came to office about a little over a year ago, for most of our area, there was an agreement signed with Bell to bring fiber up to the home by the end of 2023. So technically, we still have a year to wait based on that contract that was signed. And you can follow the progress on the internet. There's a website. If anybody wants to find it, I can help direct you there. But there's also something we added to that, which is Starlink, which is coming out from low Earth orbit satellites. There's a number of people who have it, and it works well. It's different than satellite internet because the satellites are low Earth orbit, so there's less time taken to send the signal up and come back down, which decreases latency, which is the delay that you might experience if you're trying to get on the internet and do whatever you're doing on the internet. So I think it should be really good by the end of next year if things stay on schedule for just about everyone. And if people are not in the areas designated to get fiber to the home, they can start making application for a subsidized form of the Starlink access. The other thing I might throw in, and it's not internet, but it's cell phone coverage, and that's something that I think could very easily be fixed. The province owns over 80 towers right now. They're used for communication purposes. There's no reason why we couldn't own some more. If private industry doesn't want to bring cell phone coverage to the area because there's not enough money in it for them, I mean, it's not complicated. Put up towers in a number of places, lease them out. It wouldn't even cost the government anything in the long run. And if it took us 20 years to pay them off, who cares? If you bring cell phone coverage, that's more of a safety issue and also an issue probably for recruitment. If people want to move here, they want good internet, but they also want good cell phone coverage. So I'm just throwing a little plug in for that, as I often do.
Here. Thank you, Minister. Thank you.
I feel like I want to cheer for that. I live in northern Nova Scotia in a rural community that, you hang out your window and you might get a cell phone. So the power goes out, you're in trouble. And so.
Oh, thank you for taking my question. Can you hear me? So anyway, I'm not here to ask a question. I'm here to tell you a story. And my story is not a good one. It's a very, very sad, tragic story. And you guys are all in here thinking that the healthcare system is not just basically broken. I'm going to tell you, it's burning to the ground in this province. It's burning. So anyway, my wife lost her battle with triple negative breast cancer, August 22nd, 2022. And I pretty much, I was in, and she was diagnosed in October 2021. So it was a very, very fast, aggressive cancer that she had. So over the 10 months, I witnessed everything in healthcare from a bird's eye view. I'm going to start with cancer treatment. We had Dr. Annette Drucker and Nurse Morella. They were the outstanding oncologist and our outstanding oncology nurse. Their hands are tied with red tape in this province and in Canada, to tell you the truth. They tried everything. This cancer was very, very aggressive. And Dr. Drucker actually told me that she's only the second patient in 10 years that he had this actually happen to. We did a lot of research on this cancer when she first diagnosed, and we found out in the States that immunotherapy was actually beating this type of cancer. In Canada, immunotherapy is approved for many types of cancer, but it was not approved for triple negative breast cancer at that time. So Noelle did 31 years in the military. And she retired in July of 2021. And she was diagnosed. She found a lump in August. She got her mammogram in the end of September, and Dr. Gregory Knapp, the breast surgeon, told her she had triple negative breast cancer, October the 8th, 2021. In that time, the next visit we had was with Dr. Annette Drucker and Nurse Morella. So we put forth that we really wanted to go for the immunotherapy. So Dr. Drucker informed us that he could not prescribe it at that time because it was not approved for her or for triple negative breast cancer patients. So we went back home and he had a plan all set out to start her chemotherapy. Before she got her first chemotherapy treatment, he called us at home. And he said, I found a way, I think I can get you this immunotherapy. Because you are in the military, you can go to the military doctors, because there's different set of rules for military people, and they can actually get you this treatment at a private clinic called Bayshore, which is on Bayers Road, and I'll get to that later on. It's on Bayshore and Bayers Road, and the therapy costs $10,627.27 plus $250. When we informed Dr. Drucker that Noelle was actually retired 3 months, that plan was off the table because his hands were tied with red tape. She couldn't get it. So she started a battle of chemotherapy. So Noelle did 8 rounds of chemotherapy, a mastectomy, 15 treatments of radiation, oral chemo, and then in the spring of 2022, guess what happened? Triple-negative breast cancer immunotherapy was approved in Canada. However, there's criteria for this cancer. The criteria was, number one, it had to be the first initial attack on the cancer using immunotherapy. Obviously, that couldn't happen because she was after getting all these other treatments. The second piece of the criteria was that you had to be off chemotherapy for 6 months, and then you can get the immunotherapy. Now, can you imagine taking 6 months off and this cancer's now raging through your body? That's impossible. And Dr. Drucker told us, he said, if you stop chemotherapy, I'm not going to be your doctor no more. But the good news about that was he could actually prescribe this drug now. So he prescribed this drug to Noelle, and we paid the money. And we went. We got the treatment. It was on August 2nd. We got our first treatment. So $10,627.27, plus they charge us $250 to get the treatment, right? I wrote a letter to you, Minister Thompson, and I've been in contact with Alan over this whole time period, and Grant was good enough. He got back to me numerous times, and he wrote me a letter on it. And basically, the criteria is made by the drug companies and by their, as you guys know, they have scientists or whatever that sit on these panels, and they decide what criteria is used to use this drug. So Dr. Drucker made the decision for us. He said, your best chance of survival right now is to actually get the immunotherapy along with your chemotherapy. So, and her chemo went from every 3 weeks to every 2 weeks. So she'd get chemo 1 week, then the following week we'd drive to Bayshore and we'd get the immunotherapy. We couldn't even get the immunotherapy in the hospital because it wasn't funded by the Nova Scotia government or the healthcare system. We had to actually go to a private clinic to get it. Now, you guys probably all know how hard chemotherapy is on a person. I'm telling you right now, with Noelle, she could barely walk when she had chemo. She was struggling to walk. And we went and we got it, and we got it done. However, it didn't work. It was too late for her. It's too late. She passed away on August 22nd. Now, you may wonder why I'm here arguing about immunotherapy. If you guys go back on June 8th, 2022, and go on to Today Show, and there was a doctor on a Today Show, and they did a trial on immunotherapy. It was on colon rectal cancer patients, okay? And it was done, and they had 16 people in this trial, 16 men. And 12 of them were already done the trial. It was a 6-month trial. And to be clear, it was only a percentage, 5 to 10% of colorectal cancer patients have to have this mutation for this immunotherapy to work. These 16 people had this certain mutation. Well, 12 of them were done the trial after 6 months, and guess what? 12 of them are cancer-free. It's the first time in the history of cancer treatment that 100% of the patients were cancer-free. Now, if you guys didn't see that, I recommend you go and watch that interview. Pull it up on YouTube. June the 8th, 2022, the Today Show. So that was part of Noelle's treatment. Now I'm going to get into emergency clinics. So Noelle, because the cancer went through her body so much, she ended up having pleural effusions. The first one was in her left lung, and the second was in her right lung. So the pleural effusion got blocked, the left one. So we decided we were going to go to the Halifax Infirmary to get this taken care of, this blockage. We went down to the Halifax Infirmary. We went in, we sat there for 12 hours. And like was brought up by Bonnie and numerous other people here, there's, if you've ever been in the Halifax Infirmary, there's one hallway there, I don't know, 17, 20 rooms. They call it Paramedic Alley. So in there, they're so busy in that clinic, they're run off their feet. And we seen by the doctor once, Dr. McKinnon, beautiful lady, came in, and a couple of nurses. And by the end of the 12 hours, the decision was made that would have to come back to the hospital the next day to see a thoracic surgeon to get that drain unplugged. Well, the next morning she woke up. She couldn't walk, couldn't breathe. I said, we got to go to Cobequid. We went down to Cobequid, got in the ER. Again, excellent people. Everybody working in these ERs are the nicest people, the greatest people on earth. Dr. Best came in. I don't know if anybody in this room knows Dr. Best, but I'll never forget him. He came in. He's the most energetic doctor. He looked at Noelle and said, I'm going to fix you. I'm going to get this this drain unplugged. So what he did, he said, the thoracic surgeon on duty today is my friend. I'm going to give him a call. So he called him. He had to get permission to use a drug. And the drug that he had to use was actually a drug that they use on if you had a stroke patients. I don't know the name of this drug. So he injected this drug into her drain. We were there for 7 or 8 hours. The first one didn't work. He said, I didn't give you enough. He came back, gave the second one, hooked the drain up, wham, 1,000 milliliters came off her lung. And she could actually breathe. Now, why do you think there's differences between 2 emergency clinics? I'm going to tell you why. Because they run off their feet down there at that Halifax Infirmary. They don't got time to do that. She didn't have time to even go talk to the thoracic surgeon, Dr. McKinnon, because she's running between 20 rooms. And 4 or 5 of those rooms, there's people in that clinic that are there. You know what they're there for? They're there to get a sandwich. They're there because they're hungry. And I'm going to talk about the ambulances. There's 4 or 5 ambulances sitting out in that cul-de-sac with 8 to 10 paramedics standing with 4 or 5 people that they're emergencies, that they're hungry, looking for sandwiches. So you're tying up 10 paramedics and 5 ambulances that could be used somewhere where people are dying because of this. Something has to be done to change that. I'm telling you right now. Dr. McKinnon told me this happens on a daily basis, and she also told me this. She had a patient in there the night before that came in and said, what's your problem? He said, I'm hungry. She said, okay, I'm going to get you a sandwich. He got so irate with her, he said, no, I want chicken. You can't give me a sandwich today, I want chicken. This is happening. This is not a joke. Okay. Shortages, doctor shortages, next one. I retired from the military in 2015. I did 25 years. I didn't have a doctor for 4.5 years. Thank God Dr. Nicole Robichaud came along and took me on as a patient. Noelle retired in July 2021. And when she did, Dr. Nicole Robichaud, she agreed to take Noelle on as a patient, and she's an amazing family doctor. But you know what? She's going to get burnt out like the rest of them. You better, if you're got an appointment with Dr. Robichaud, she's amazing. She actually said she'd come to our home to see Noelle. You don't hear many doctors these days doing that. She was going to do a house call. She's an amazing doctor, and she's from New Brunswick, and she came to Nova Scotia. But she's overwhelmed. You better have your ducks in a row if you're going in. You have 15 minutes, and that's it. And she's a young doctor, and I bet you after 5 to 10 years, she's going to be burnt out. We need more doctors. Okay. I already talked about the red tape. No, I'm going to talk about Dr. Anik Drucker again. Red tape. He told me when he first started practicing oncology, wasn't very long ago, I'm going to say over 10 years ago, he had to sit in his office and he had to write to different companies, Health Canada, whoever, to get permission to use drugs on certain patients. He was writing on 4 drugs at that time. He told me, and this is his numbers, not mine, he has to sit in his office and write over 200 drugs now to use on patients. So when he's not practicing in his office in the clinic, 8 to 10 hours every day, he's spending writing permission slips to get permission to use drugs on cancer patients. Now, he's a very young oncologist. He told me this himself. He said, I'm at the point with the red tape in Canada and Health Canada and everything else, I'm ready to pack it in. You think we can afford to lose Dr. Drucker? I don't think so. So the red tape, again, I know Health Canada's got to get involved here in Nova Scotia as well. Nurse shortages. This is a big one. Nurses are short everywhere. It's to the point at the VG hospital. We were on floor 6A. So basically, I'm going to tell you a couple of stories about that floor, and you're not going to like them. There's nurses on that floor looking after 8 to 10 patients a night. They're run off their feet. They don't got time to do nurses' work. They can only go in there, take your vitals, give you medication, and move on to the next patient. Noelle was in a room with 2 other patients. One guy's name was Kim. The other guy's name was Patrick. I'm going to tell you a story about each one of them. However, there's nights in that room, the nurse will come in, excellent nurses, outstanding nurses. They'll come in, introduce themselves to the room. 10 minutes later, they come back to the room, said, sorry, I just got called to go to another floor because they're short on that floor. So now 6A's now short. So now they're spreading out the shortness. So every single floor in that hospital is short of nurses. There was another nurse, the last time Noelle was admitted to the hospital was August 18, 2022. She got admitted, and she was put in a room in 5A, 1 floor below. The young nurse that was in, just starting her career out, she was from the Waterford. She told me this. She said, I said, he's your nurse, how do you like it? She said, well, I had a full-time job when I started. I came out of university. I came here. I got a full-time job. I had to drop down to 50% because I was leaving this hospital every night crying my eyes out because I knew I didn't give the care I should have to these patients because I'm run off my feet in here. And this is happening to all the young nurses. I'm telling you right now. So, again, the Cobb Quid ER. We were there one day. And this is the day Noelle got her drain cleared. We went into the ER. There was 1 nurse on the floor in the Cobb Quid ER. I don't know if anybody's in there into the Cobb Quid ER, but that's a very, very busy hospital as well. Outstanding people. This nurse came in, and she told us, I was here till 1 o'clock in the morning last night, and we were there first thing in the morning. I'm going to say it's probably 8 o'clock, 7 o'clock in the morning. I was supposed to start my vacation today, she said. I got called in. I'm the only nurse here right now, because all the other nurses called in sick. She was, again, this was supposed to start her vacation. They said this happens all the time. The scheduling, there's no scheduling really. She said we're called in overtime all the time because there's just no nurses. So I'm going to tell you a story about a pleural effusion. When Noelle got her pleural effusion the first time in her left lung. So I don't know if anybody here knows a doctor called Dr. Harry Henteliffe. He's a thoracic surgeon. He is an outstanding doctor. He's just about to retire himself, which is too bad. So the decision was made that Noelle needed to get a drain put in her side. So we went to the hospital, and I dropped her off at 6 o'clock in the morning. She got admitted to the hospital. I wasn't allowed to stay because of COVID rules. I stayed till 7 o'clock. Her operation was scheduled for 10:30 in the morning. So they came in, they did a COVID test. She called me at 7:30. She said, I just tested positive for COVID. She had no symptoms whatsoever. They did a PCR test on her. They isolated her in the room in the hospital. And at 10:30, we're supposed to be in the OR. She called me. She said, I don't know what's going on. No one's come up here. I'm supposed to be in the OR right now. She can't breathe. She's in panic mode. She's crying on the phone. Crying. I said, I don't know, honey. They're going to come back. Just take it easy. She asked for a blanket. She was also freezing to death. They never came with a blanket because they're too short again. They run off their feet. At 10:30, Dr. Harry Henteliffe shows up on the floor and says, where's my patient at? She's supposed to be in the OR right now. And the nurse said, well, she tested positive for COVID. He said, I don't give a damn she tested positive for COVID. This lady needs a drain. She can't breathe. And she needs an operation. He said, this does not change my job one bit. I just got to put an extra mask on to actually put this drain in her. And then he said, and then they came back, where's the PCR test? Oh, we lost it. They lost the PCR test on her. They had to do another PCR test on her. He took her to the OR anyway, and he did the drain. So the operation basically called me around an hour later, probably around 12 o'clock. He told me the operation basically took 10 minutes to do for him. So he said, she's in the room right now. We drained 1,000 milliliters off her lung. There's still a lot of fluid left in her lung. I couldn't drain it all off because he said, it's dangerous, we can collapse her lung. And he said, she's going to have to get it drained later on today, but it has to be done slowly. So I said, well, can I come see her? He said, absolutely, come to the hospital right now. So I drove down to the hospital. I had a gown up, put the mask on. She's in the bed. I go in the room. She's laying in the bed. She can breathe. She's so excited she can breathe. We're talking, right? We're talking like this. In comes this young male nurse, training to be an RN. Excellent nurse, excellent guy. Talking to her, taking her vitals, doing all his checks. I see him, he hooks up a drain to her. So we're talking like this. All of a sudden, 5 minutes goes by, Noel heels over on the bed. I look down on the floor, there's 1,000 milliliters in the drain bag. He drained her like that, put it on wide open. I said, hey, bud, I talked to the guy that did that. You're supposed to drain that slowly. He said to me, oh my God, are you serious? He said, I didn't know that. I said, you didn't know it? You're a nurse here. He said, you know what? He said, I'm trained to be a nurse. We're so short, there's no mentorship going on. There's nobody with this poor young guy to show him how to do his job. That's a problem. Very big problem. This guy was a good nurse. I'm not joking. He was very good. So I'm going to get to the point where how doctors are short. Doctors are short as well. And I'm going to give you a story about Kim. Kim was a man who was Noel's roommate in 6A. He was in the hospital for 3 weeks. He had blood clots in his legs. He's probably 60 years old. Great shape, big, tall, skinny guy. They had no idea why he was getting these blood clots, so they kept him in the hospital. So what happened was, the doctors, the surgeons that were looking at him told him, you got to lay in bed, and you can only walk from here probably to where that speaker is, to the bathroom and back in your bed. 3 weeks goes by. He's in that bed. He don't move. The head of thoracic surgery comes in. And we're sitting there talking to Noel like this. His wife and Kim are sitting there and starts doing a conversation with him and asks him, well, how much exercise are you getting? He goes, what are you talking about? Well, are you getting up, walking around the hospital, going down the floors? He said, oh, no. Your team told me I was only allowed to go to the bathroom and back. That's what I've been doing for 3 weeks. She goes, no, you should be up walking around the hospital. You should be going outside. He said, I got an idea for you. How about all your doctors on your team get together in a room in the morning, come up with a plan about your patients, and then send them in to tell us when you guys agree what the treatment should be for everybody in here. The reason why they don't do that, if you've ever been on that floor, they're running up and down the floor like chicken with their heads cut off looking at patients, all these doctors. They don't have time to sit in a room and talk about a certain patient. Doctor shortages. Well, since I'm on that room, I'm going to tell you a story about Patrick. He was the other roommate. Patrick was a gentleman that was in the hospital for 3 weeks with Kim. Noel was there for 10 days with him. He was in the right bed. He laid in the bed. He used the bedpans. He didn't get up to use the bathroom, nothing. He rang the nurses constantly for stuff, this guy. Never got up once to use the bathroom, using the bedpans. You want to know how many times his bed sheets were changed and how many times he was cleaned in 3 weeks? Once. One time. That's it. And the reason he was only cleaned once because they don't have people to do it. Not because they don't want to do it. They're too busy to do it. So anyway, Patrick has to go for an operation. It's 10 o'clock at night. We're sitting there. Kim's on this side. Noel and I are talking. In comes this stretcher. You think it was a porter that was pushing the stretcher in to take this guy for an operation? No, it was the surgeon that was coming up to get him out of the room. The surgeon had to come up out of the OR, put him on a stretcher, and take him down to the OR to get his operation. It's not right. Oh, supply shortages. I got a bunch of notes here. Supply shortages. So the thoracic surgery ward, that's where all the drains are put in. Noel had 2 drains. You had one on the left, one on the right. So I had to do the draining. I did the draining for her. So I went to the actual, up to the desk. I said, can I get some drain bags so I can drain Noel's drain? The nurse at the desk said, well, you're going to have to come back in 10 minutes. 10 minutes? Why? We got to drain IV bags out so we can give you a drain bag. I said, really? I said, VON, I got a case of these drain bags in my living room home. She told me, we can't get them here. This is her words, not mine. So I mean you can't get them. So from that day forward, I took my own drain bags to the hospital. I actually also took my own bandages to the hospital to change her bandage from her mastectomy. Oxygen bottles on that floor. They're not, numerous times had to go get oxygen bottles. They weren't full, but the nurses are very good. They'll get them full when you should tell them, but there's nobody checking on these bottles. Cleaning, I had to clean the shower before Noel took showers. There's not enough cleaners in the hospital. Top everything else off, you got to go down there, you got to pay for parking. So that's the first part of my story. Now I'm going to get into her. So she was diagnosed, like I said, with triple-negative breast cancer in October 2021. 8 rounds of chemo, like I said, 15 radiation treatments, oral chemo, 1 round of immunotherapy. August 26th, she found the lump. Went to Dr. Nicole Robichaud. 21st September, she had the mastectomy. October 8th, diagnosed with triple-negative breast cancer. Her body was chemo-resistant. The tumor grew and did not shrink. Her oncologist, Dr. Anik Drucker, tried 2 types of chemo combinations, meaning each cycle had 2 to 3 types of chemo in each. However, it did not work. He said this is the most aggressive chemo he could ever put in a person. Mastectomy operation was in March 2022, Dr. Greg Knapp. June 22nd, she went to oral chemo. Then she started 15 radiation treatments, Dr. Hannah Dawn. So July 2022, she completed radiation. A week later, Dr. Drucker decided to move on the IV chemo, being the most aggressive way to fight it. And she died August 22nd at the young age of 50. Her chemotherapy was every 3 weeks, and the last treatment was every 2 weeks. So she retired from the military July 2021, 3 months prior to her diagnosis. Did 31 years in the Canadian Army as a physician's assistant. You can actually hire them in this province too to be like a nurse practitioner. When she first started this awful journey, she joined numerous triple-negative breast cancer groups, and like I said, they're all getting immunotherapy. And she asked for this treatment from day one, and because of the red tape, she could not get it, and we'll never know if that would have been the difference in her battle or not. I'm hoping that down the road it'll be in somebody else's battle. I don't know about you guys, but if you were told you had to pay $10,609.27 for Keytruda, it might save your life, would you do it? I'm going to tell you would. We were ready to sell our house. We were going to sell everything if this treatment started to work. We were going to do it, but thank God, there's 4 people in Halifax or in the VG, and their only job is to fight for patients with insurance companies. And ours, her name was Crystal, I think. She was amazing. She fought for Noel, and she fought and fought and fought. And Dr. Anik Drucker, he fought, and he wrote letters. And thank God, well, not thank God, it wouldn't have mattered, but thank God that they did agree to pay for the treatment. The insurance company did pay for it in the end. So I'm going to give you the icing on the cake with everything. I know I'm rambling on here, but this is one that I think I got to bring up. So this happened on Saturday, August 20th. Noelle was diagnosed on the 18th of August on a Thursday, and Dr. Drucker told us at that time that there was no more treatment that she could get, and basically she was put in room in 5A. It was like, it wasn't a palliative care unit, but her room was for palliative care. And she was only be there in that room for comfort measures only. Noelle pleaded with him. She couldn't breathe at this time because the pleural effusions were full up, both of her lungs. She pleaded that she wanted another immunotherapy, which she was scheduled to get on Monday, August the 22nd. And Dr. Drucker told her, he said, if you can breathe on Monday, we're going to send you for that treatment, knowing full well that this was not going to happen. So he told me on Thursday, he said, you better call all your family and friends to come because their time is getting short. So I called everybody, and a lot of people travel from the province, from here, from the valley, from the Glasgow. And on Saturday, a lot of people showed up on Saturday. Noelle had a very busy day on Saturday. She was very tired. And about 9 o'clock at night, or 9:30, we had family there. She said, why don't you go home, get a night's sleep? So I was in the hospital with her from Thursday, Friday, and come back in the morning. I'm just going to sleep tonight anyway. I said, okay. I didn't want to do it. I had a funny feeling about this. I did do it. I went home. So anyway, I left my name with the front desk. It was on her chart. I put my name on the whiteboard. And on her chart, it said on the chart, she is here for comfort measures only. She didn't have any IVs in. She couldn't get an IV because of her veins were too flattened. She was getting oral medication and needles for pain and to keep her comfortable. And she was talking fine. So I got up at 6:30 Sunday morning. I get a phone call from the nurse that was on duty that night. She said, I'm calling, is this Mr. McDonald? Yeah, it's me. I'm calling to inform you that this is the nurse on duty, and we had to move Noelle to the ICU last night at 2 o'clock in the morning. I said, what are you talking about? She goes, yeah, we had to move her. Her breathing was too bad. Well, we know her breathing's too bad. She's in there, she's in the palliative care. You're not supposed to move her without contacting me. This is 5 hours later. They contacted me that they moved her. So I jumped in my car. I raced as fast as I could to that hospital. I went to floor 6B, which is in the VG, and I went in there. And I went up to the desk, and I was mad. I'm not going to lie. I was pretty much an irate at this point. And I said, where's my wife at, Noelle? And there was a nurse sitting there, and there's a guy in the back corner, and he gave me one of these smirks and a stare. And I lost it on this guy, I'm not going to lie. I said, listen, buddy, I'm not in the mood for your smirks right now. I got to find out where my wife's at. And I was raging. And he said, I'm going to call security. I said, you go ahead and call security and do whatever the hell you got to do, but I want to find her right now. So anyway, I calmed down, took me into the ICU. Noelle was hooked up to an oxygen mask, IV. She had heart monitors on. She had a blood pressure cuff on her arm, and she had that oxygen on her finger, the O2 sensor, whatever you call it. She seen me come in, and she's scared to death, right? She's scared. And the last one, not the last thing she said, but one of them, she looked him in the eye and said, I'm dying, I'm dying. And I grabbed her by the hand. I said, no, honey, you're not dying. We're going to get you out of here. You're going to be going back down to your room. And as I'm saying this to her, Dr. Morgan, who is an oncologist on duty, amazing doctor again, she came in, she looked at me, she said, I'm sorry, mistakes were made. Noelle should not be in here right now. I'm in the process of getting her put back on the 5th floor. I said, thank you very much. And she got her back there. And within the hour, Noelle was back down on that floor, on the 5th floor. I went back up to that floor, and I apologized to all them people in there. I said, it's not your fault. It's not your fault that this happened. That night, Sunday night, the nurses came on that were on the night before. I went to the head nurse, and I said, what happened? And she tried it, and finally she let the cat out of the bag. She said, well, what happened was we had a training nurse on last night, and we had a resident doctor on who went in to assess Noelle with they had no mentorship, and they did the right thing, if you think about it. She's a 50-year-old woman, her oxygen levels are dropping, she can't breathe. The radiologist did not read the chart, the training nurse did not read the chart, they shipped her right up to the ICU, and in the words of the head nurse, she said, we didn't have enough people on duty to care for her on that floor. And you know what? All they had to do was keep her comfortable. If they had to read the chart, that would not have happened. And you can imagine how scared you'd be if you went up to that floor, you're in the last days of your life, and they're hooking you up to all this stuff. That's what happened. So she's supposed to get her next immunotherapy on August 22nd. Unfortunately, that's the day she passed away. She never got that. So I want to finish this up. I'm sorry I took too much time, but I thought this was a story that had to be told. So Noelle gave her life to this country. It was all over the world. Numerous tours to Afghanistan, United Nations sanctions, as well as humanitarian aid to foreign nations after natural disasters. Her main job as a medic and a physician's assistant was to help others. She retired from the military after 31 years of exemplary service, and she needed your help, and quite frankly, she did not get it. Noelle diagnosed, she deserved better from not only Canada, but from our home province. She deserved better. Alan and Michelle, your help with this matter would have been greatly appreciated, and I hope this will actually cut some red tape and get some stuff moving in this province and hopefully save someone's life. Someone's lives, and maybe one of your days. Maybe someday you'll be the ones looking for this treatment. Hope it saves a life. I want to thank all of Noelle's healthcare workers. They did what they could with what they had. They were outstanding. I can't remember everyone's name, and Noelle's doctors and nurses, but I want to thank all the doctors and nurses that are in the Halifax Infirmary Emergency Room, the Coquitlam Emergency Room, Dr. Nicole Robichaud, Dr. Craig Knapp, Dr. Anna Drucker, Dr. Hannah Don, Dr. Harry Anteleff, Dr. Best, Dr. Muhammad, and Dr. French, oncology nurse Morella, and Inverness oncology nurse Melinda McDonnell, who Noelle leaned on numerous times. In closing, I'm glad this is being recorded, and I'm pleading with you to play this portion to the entire Nova Scotia legislature, because we don't need just a current political party in charge to fix the healthcare system. We need everyone. Stop trying to be funny on TV, making fun of the other party, and start working together to fix this problem. You guys are the smart people that we voted in to work for us, and now it's time to get to work. Maybe you should find out where the best healthcare system is in the world and get some of that leadership from that country to come to Nova Scotia and get you going in the right direction to fix this problem. I was told by one of the greatest bosses I ever had in the Navy that if you fail to plan, you plan to fail. Well, Nova Scotia government, I'm not just talking about the current government, this goes back years, if not decades, you failed. You failed to plan for doctors, nurses, and healthcare worker retirements. You failed to plan for aging population and immigration, and you failed your constituents on healthcare. You all were brave enough to put your name on a ballot and get voted in. I hope you're brave enough to go to every hospital in your region and start at the bottom of that hospital, shake every single hand of every healthcare worker, tell them you're sorry for the situation you have them working in, and then thank them for working in this environment. Because believe me, each and every one of them are heroes in my book. Thank you.